Thank you, Dr. Staudinger, and thank you, everybody, for coming this afternoon. It is my pleasure to introduce Anhthu Tong. Before joining KCU, she received her BS in Neurobiology from University of California, Irvine, and her MS in Biomedical Sciences from George Mason University in Manassas, Virginia. In 2018, she was a global health participant for the Remote Island Medicine Program in the Philippines, where she studied and participated in the care of rural public health in the remote villages. Anhthu is an active member in the American Medical Women's Association, Missouri Association of Osteopathic Physicians and Surgeons, and the Student American Academy of Osteopathy. She has been an active volunteer throughout her career, including volunteering for things such as compassionate listening, childcare, vision clinic, and animal care. During the COVID-19 shutdown, Anhthu acted as a COVID line clinical assistant, facilitating health calls and COVID-19 screenings between clinicians and the uninsured people of Colorado. She is also a contributing author on the COVID-19 resource document found on the Canvas site. And if I could please remind everyone to mute their mics and raise their hands for questions, Dr. Staudinger or myself will help moderate the questions. Anhthu, I will hand it over to you. Please take it away.
Thank you, Shelley. Thank you, everyone, for joining me today. Now, I typically cover OBGYN, nephrology, indirect medical consequences of our COVID-19 resource document, but I have decided to cover this particular demographic in honor of my maternal grandparents, and as well as elderly patients. My grandparents have helped raise my sisters and me throughout our childhood while our parents worked full-time. And this month, I have the pleasure of caring for my elderly patients at the Life Care Center of Aurora, Colorado, which caters to patients needing skilled nursing, short-term rehab, or post-op recovery. Before diving into the first article, I'd like to briefly review my outline. So the way that I have this set up is we'll review the clinical features seen in the elderly, and then we'll discuss antithrombotic therapies. So with that, let's begin with the article entitled Clinical Characteristics of Elderly Patients with COVID-19 in Hunan Province, China, a multi-center retrospective study. So by now we're familiar with some of the clinical manifestations of COVID-19, such as fever, cough, and shortness of breath. As more research emerges, however, we're finding that the elderly often have an atypical presentation, which may delay proper diagnosis and treatment. These atypical symptoms may include fatigue, loss of appetite, or altered mental status. And we'll get into the possible reasons for this as we dive in deeper. As for imaging, we've been seeing ground glass opacities with or without consolidation, which is consistent with viral pneumonia. And patients with COVID-19 often present with these abnormalities in the lower lobes of both lungs with a peripheral distribution. Here, multiple round ground glass opacities can be seen along the periphery of both lungs. Next, let's take a look at the age breakdown as it relates to hospitalization. Here we see that the risk of hospitalization increases with age. And for the purposes of this article, we'll be focusing on those aged 60 and over, which brings us to the objective of this article. So the aim of the study was to not only analyze and summarize the clinical characteristics of elderly patients with COVID-19, but also compare the differences of young old and old patients. The study defined young old patients as those between the ages of 60 and 74, and old patients as those 75 and over. Now, the methods of the study involved a retrospective chart review, which looked for patients hospitalized for COVID-19 across 8 different regions within the Hunan province between January 21st and February 19th. Out of 565 admitted, 105 were aged 60 and over. And of the 105, 85 were further classified as young old, while 20 were classified as old old. Now, the clinical outcomes of these patients were followed up until March 11, 2020. At this time, I'd like to take a moment to point out that no clear hypothesis involving these particular age groups was delineated, and there will be more on this later. With that said, let's take a look at the results, starting with the demographics and baseline characteristics. So in the first column, we have the total number of patients of both groups, or from both groups, with the first number seen here indicating the median, and the number within the parentheses indicating the interquartile range. Each number thereafter denotes the head count, with the number in the parentheses denoting the percentage of the group for that column. In the neighboring columns, we have the young old group and the old group, and the p-value, which was considered statistically significant if found to be less than 0.05. If we focus on the general demographics and baseline characteristics of the entire group, then we see that the median age was 67, and more than half of the group was female. 69.5% of our elderly patients had chronic comorbidities, of which the most common were found to be hypertension, diabetes, and cardiac disease. And in looking at the data thus far, I can deduce that the null hypothesis is that the difference in frequency of X characteristic, clinical feature, or lab finding between young old and old is due to chance. For example, the difference in frequency of chronic comorbidities, seen in this line here, between young old and old is due to chance. This makes sense in the context of a generally increasing prevalence of chronic comorbidities that occurs with age. And after a certain age, the frequency of chronic comorbidities becomes irrelevant. However, without an outcome variable such as mortality, illness severity, or complications, it is difficult to find any clinical implications for these p-values. And the authors here were also quick to apply p-values that may not be defined, such as the one here for age. So the table continues on with signs and symptoms. On admission, the most common symptoms seen were fever, cough, and fatigue. However, there was no relationship between the two groups with respect to frequency of these signs and symptoms. And to finish off table 2, we have illness severity. And as seen here, the median incubation period of our elderly patients was 8 days, and there was a median of 5 days from illness onset to hospital admission. 61.9% developed moderate disease, while 22.9% developed severe disease. And no statistically significant relationship was found between the two groups with respect to any of these parameters. And moving on to the next table, we have lab findings and imaging. Overall, 30.5% had a decreased white count, while 63.8% had a normal white count. Continuing down the table, we're seeing that 31.4% had lymphopenia. And according to the highlighted p-values, no relationship was found between the two groups with respect to white count or lymphopenia. And this is in contrast to the next set of p-values. Here we see that the median prothrombin time, or the time it takes for the blood to clot via the extrinsic and common pathways of the coagulation cascade, is normal in both groups, but slightly longer in the old group. Same was found for activated partial thromboplastin time, or the time it takes for the blood to clot via intrinsic and common pathways. And this pattern is seen again with both BUN and creatinine. After reviewing this with my former resident, now attending Dr. Coe, I've learned that the statistical significance of these parameters offers no clinical significance in everyday practice. Generally speaking, prolonged PT and APTT may be seen secondary to COVID-19 induced hypercoagulability. However, differences in prolongation would not impact the care that these patients receive. And moving on to imaging. Bilateral pneumonia was seen in 88.7% of patients, and multiple modeling with ground glass opacities were seen in 40%. These imaging findings are what we've been seeing across the age distribution and what we discussed in our background earlier in this presentation. And finally, we have table 4, which covers the complications secondary to COVID-19. Here we can see that the 3 most common complications were acute respiratory distress syndrome, acute cardiac injury, and acute kidney injury. The p-values that I've highlighted off to the side show that there was a statistically significant increase in the frequency of the complications occurring in the old versus the young old. And to finish off table 4, let's take a closer look at prognosis. As of March 11th, 85.7% of elderly patients have been discharged, and there was a 2.9% mortality. However, there is no statistically significant difference in discharge and mortality rates between the two groups. So with that, our conclusions of the study were the most common symptoms being fever, cough, fatigue, and there was a high incidence of moderate to severe disease among elderly, irrespective of age, past 65. More complications were seen among old than young old in the hospital setting, with old also requiring more invasive, with a greater frequency of old requiring invasive mechanical ventilation, And now I've highlighted the results seen in the previous slides in my presentation, as the authors have highlighted them in their paper. However, even with all these statistically significant differences in lab findings, there are no clinical implications. In other words, the p-values don't add up, don't really add any value to this paper. And I believe that the more important takeaway are the general clinical features that can be seen among those age 60 and over. So with that, I've added this line here that statistical significance doesn't necessarily equate to clinical significance. So going over some limitations. First of all, the sample size was rather small. In previous studies, we've seen that there's a greater prevalence of COVID-19 and related complications among males. So a larger study is needed to investigate whether there is a gender difference in COVID-19, especially among the elderly. There was limited patient information, particularly the medication list, which was unavailable. And so it's difficult to assess whether drug influence played a part in some of the lab abnormalities. And follow-up was limited to only March 11th. And so it's unknown whether there are any long-term outcomes, such as the influence of pulmonary function or the possibility of lung fibrosis secondary to COVID-19. Any questions?
We're open for questions now. Go ahead and raise your hand if you have a question for our student doctor. Dr. Schneider.
Anhthu, thank you for presenting this information. Anhthu, while you were preparing, did you see this specific information in regard to hypertension? So is that stage 1, 2, 3 of the disease? There is any relation to how high blood pressure was in those patients? Were the patients, let's say, stage 2 of the disease and 3 in that category where we say it is one of the main risk factor, hypertension?
Off the top of my head, or from what I remember about the paper, I don't believe that the authors actually went into detail about the individual comorbidities, and so I am actually not sure, but I can look into that and get back to you.
Yeah, I understand, because that was another lecture. That's why I asked, while you were preparing, maybe you saw this information. All right, thank you.
No, I have not.
All right, thank you.
Any other questions for our speaker? Shelley Boyer.
Thank you, Anhthu, for the presentation. I was just curious, I think that this paper kind of backs up what we're seeing with the older population. I don't know that we can really differentiate between, the old and the young old in this paper, as far as if one group was maybe worse than the other, except for, in the one mechanical ventilation. But again, the population size was small. So I guess where I'm going and what I'm wondering is maybe could we apply anything else as far as, I know this came out of China, and I know that, we've looked at some of the living conditions. They tend to live with more people. Maybe this elderly population coming out of Wuhan, maybe, I don't know if that had something to do with it too, or if we can just equate this to age overall and what we're seeing in COVID-19.
I don't know if I got your question.
I guess when we look at the other things, minority population, socioeconomic conditions, when there's multiple generations living in a household, if some of these other factors could have maybe played a role in what we're seeing, or if we can just simply chalk this up to, once you get in a certain age group, these comorbidities and some of these things play a role, and it's just kind of bound to happen more or less if you're, at this risk group.
I see what you're saying. I do believe that there are several factors that weren't considered in putting this together, because you're right. Close quarters can have an effect. At the skilled nursing facility that I'm rotating at, we had a census of about 90 to 95 patients, 40 of which were diagnosed with COVID-19 in the last few months, or been a while, but it's in the first few months of the pandemic. And here, the rooms are set up in such a way that some of our long-term care patients have 2 patients to a room. And so I rotated here first in February, and now that I've come back, I'm noticing that a lot of the roommates are, first of all, we're at half census, and second of all, we're at 1 patient per room for all the rooms.
Okay, yeah. Yeah, no, that makes sense to me. I think that some of that would have played a part potentially in some of the numbers you see and what's happening in the nursing homes. With 2 patients to a room, I think you're going to have an increase of spread on top of more susceptibility that's already there, whether or not certain protocols have been put into place at some of these healthcare facilities. I know we've seen that potentially hand washing and PPE being changed in between rooms was maybe not done at some of the nursing homes that were kind of hit really hard in the beginning. And I think that's because people probably weren't aware or as aware as what we should have been. So I guess another thing I want to point out is just the time frame. This study ended in March, and we see here in our country that it didn't hit until after that. So it would be interesting to kind of do some of this young, old population studies in different countries to see if maybe there was some genetics or ethnic roles that are also being played in any of this. And then I guess, sorry, I'm talking so long. I guess my last thought too was that some of them were diagnosed by just clinical symptoms, right? So they weren't confirmed by actual tests. Is that correct?
I believe that's in the next study.
Okay.
All
right. Sorry, I'm jumping ahead, everybody.
No, it's okay.
Thank you again, though, Anhthu. I appreciate it. I think it opens up a lot of questions for maybe some study. This looked at, a certain population in a geographical area. So I think looking at other areas would be interesting as well.
Mm-hmm. Thank you, Shelley.
No more questions. Let's move on to the next one.
Okay. So our next article is entitled Mortality and the Use of Antithrombotic Therapies Among Nursing Home Residents with COVID-19. And it's worth noting before we proceed that while this article has been accepted for publication and undergone full peer review, it has not been through the copy editing and proofreading process. Now, before we dive in, let's review some background information. So nursing homes are known to be especially vulnerable to respiratory disease outbreaks, and COVID-19 is no exception. The article goes over some risk factors for poor outcomes secondary to COVID-19, which include immune dysregulation, chronic systemic inflammation, reduced pulmonary reserve, and chronic comorbidities. These risk factors may all be attributed to increasing age, and although the article lists immune dysregulation and chronic systemic inflammation separately, I believe that immune dysregulation that occurs with aging may actually contribute to chronic systemic inflammation to some degree. Since the article goes over specific antithrombotic therapies, I'd like to briefly go over the mechanism of action. So first we have antiplatelet therapies, which include both P2Y12 or ADP receptor antagonists and irreversible COX inhibitors. P2Y12 receptor antagonists, such as clopidogrel, work by inhibiting P2Y12 receptor found on platelets, and thereby inhibiting platelet aggregation. And platelets normally rely on ADP binding to ADP receptor to activate glycoprotein 2B3A receptors for subsequent platelet aggregation. As for our COX inhibitors, such as aspirin, COX-1 may be inhibited to prevent thromboxane A2 synthesis in platelets and its downstream effects, such as vasoconstriction and platelet aggregation. Up next, we have our vitamin K antagonists and direct oral anticoagulants. VKAs, such as warfarin, work by inhibiting epoxide reductase, thereby inhibiting the recycling of active reduced form of vitamin K. And without reduced vitamin K, gamma carboxylation of glutamate residues cannot occur, which reduces the production of active coagulation factors 2, 7, 9, and 10, as well as anticoagulatory protein CNS. Finally, DOACs, also known as non-BKAs, which include dabigatran and rivaroxaban and apixaban. These work by directly binding to the coagulation factors 10A or thrombin. Now let's review our objective. So studies suggest that COVID-19 is associated with hypercoagulability with a high incidence of thromboembolic complications, but the pathogenesis remains unknown. It is speculated, however, that hypoxia and systemic inflammation secondary to COVID-19 may lead to high levels of inflammatory cytokines and activation of the coagulation pathway. The most frequently reported thrombotic complications in hospitalized patients are DVTs and PEs. With that, the aim of the study was to investigate whether the use of OATs is associated with a lower mortality among nursing home residents with COVID-19. So another retrospective chart review in this study. And this was conducted between March 20th to May 1st, of which 727 nursing residents were found in the Netherlands. 101 of these nursing home residents were diagnosed with COVID-19, 67 of which were diagnosed via RRT-PCR, and 34 via clinical diagnosis. So due to the limiting testing capacity that Shelley was alluding to earlier, residents with symptoms concerning for COVID were no longer tested once 2 residents per facility had been diagnosed with COVID-19 via RRT-PCR. And data was retrospectively collected on age, sex, nursing home facility, past medical history, medications, and SARS-CoV-2 status. Data was also collected on the type of oral antithrombotic therapy and its indication, along with the vital status and date of death. A multivariable regression analysis was conducted with independent variables being VKAs, DOACs, and ATs, and the outcome variable being all-cause mortality. So this brings us to our first table, the results, which describes the characteristics of their total nursing home population with positive viral cultures and those highly suspected of having COVID-19, but no documented cultures. So if we take a look here, you can see that there 47.9% mortality among our nursing home residents for male. And there was this p-value was statistically significant at 0.003. And we look down here, we see that 17.8% of our nursing home residents were on VKA or DOAC, and 33.7% were on antiplatelet therapy. But there was no relationship found between those that survived and those that passed away from COVID-19. Moving on to our next table, which describes the characteristics of nursing home residents with COVID-19 that was RRT-PCR confirmed. Again, we see a greater frequency of males that passed away with a p-value of 0.022. And if we look down here again, we see that there was a 23.9% on VKAs or DOACs and APTs and 32.8%. But again, there was no relationship between the two, whether they survived or passed away from COVID. Our last table, which goes over univariable and multivariable analysis to explore the association between clinical characteristics and mortality. We see here that this further confirms the male preponderance for COVID-19 related deaths. And as far as oral antithrombotic therapies, there was decreased mortality by the odds ratio with the use of OATs, but the p-value was statistically insignificant. And it was unclear in the paper whether or not this included only the RRT-PCR confirmed, or if this was grouped together and this was the total number of nursing home residents diagnosed with COVID-19. moving on to our conclusions. So nursing home residents are disproportionately affected by COVID-19 with a mortality of 47.5%. Male nursing home residents were found more likely to have a poor outcome when compared to female nursing home residents. And OATs did not appear to improve mortality among this vulnerable population. So more studies are actually maybe needed to determine whether compression stockings or even low molecular weight heparin may make a difference. Some limitations. Now, this was a retrospective observational design, and no residents were assessed for whether there was actually an occurrence of VTEs or venous thromboembolism. And there was a questionable generalizability due to the location because the southern region of the Netherlands was most severely affected. So we may not be able to apply this data to the US, for example. And there was a potential underestimate because with knowing that the elderly may present atypically, there may be some misdiagnosis, but at the same time, we could have had an overestimate because we diagnosed a good percentage of our patients just based on clinical diagnosis alone. And of course, there is a limiting testing capacity, so we may have missed some as well. Any questions?
Any questions for our speaker? Dr. Schneider.
And I have a question for you. You briefly mentioned it in the conclusions, the word heparin. So any information whether in this study they use heparin for treatment patients?
I did not see heparin. Heparin only got a brief mention in the discussion. And only so that, sorry, let me rephrase. Heparin only got a brief mention in the discussion, but suggesting that further studies need to be made. And I haven't, in my research, found any other studies, but I haven't specifically looked for heparin. That is a good question, though.
All right. You know why I'm interested in particular. So something around beginning of March, and Biorex was published a paper which is stated that heparin binds spike protein on COVID-19 with affinity which is bypass the affinity of best antibodies possible. And that's a group from United Kingdom. So I understand that clinical studies, when they're planned and pass through the permission, so probably they did not know about it. But I'm quite surprised why that lab finding that heparin binds to spike protein is not so much widely known, whether it was, but usually, you know, when it's coming from reputable research lab, like in UK, you expect that it will be kind of spread information, and many researchers will drop on it. It may be some colleague has any comments on it.
That is interesting. I'll look into that.
So I can send you, if you send me your email where I can send you that paper, how you can find it on Biorex. So I just don't know your email because I think Tong is very common name in character.
I will email you, Dr. Schneider. Thank you.
Thank you, Dr. Schneider. Dr. Johnston?
Yes, I'm sorry. I got in a little bit late on the first one, and but I did listen to your second presentation, and I have two questions. One, what is the acronym VKA, and there was something else. What does that stand for?
Vitamin K antagonist.
Thank you.
Or in this case, I described warfarin.
Okay, got you. The other one was, is there any mention of ambulation in terms of what sizable population of people were ambulatory versus bed confined?
Unfortunately not. I didn't see that. That's a good point.
Well, that would be, I think, a risk that should be cited if that population of patients are sitting ducks if they're not ambulatory.
Even venous thromboembolism events weren't recorded, so I imagine that ambulatories, from what I remember, ambulatory status was not.
I'm sorry?
Even VTEs were not recorded or assessed.
Okay. All right. I just wondered what population were ambulatory.
Mm-hmm.
Okay. Thank you.
Thank you, Dr. Johnston. Dr. Wolf?
Sorry, I got my camera competing with someplace else. I was actually going to ask Dr. Johnston's question in terms of ambulation as well, but I was also curious about the idea of what happened to them when they were sick. Were they kept there? Because the notion that placing people in a prone position is helpful and things like that, so that it seems to me that there could have been some discrepancies in the level of care that they got. But the interesting thing that I saw just yesterday or the day before, haven't had a chance to follow up on, was that there's supposedly an association with blood type and susceptibility to COVID-19. And if that were true, it seems like that would be another variable that might really help drive some distinction here in terms of what's going on.
Can I comment here that other paper showing that about 67% patients have with COVID have type 2 blood too? Yeah. So. Oh, sure. It's sorry. That's A. All right. So there are several systems. Okay. A. 67 approximately % patients with severe form of COVID have blood type A.
Any other questions for our speaker? Student doctors? Okay, seeing none, I would ask that we could reveal ourselves with our cameras and give our speaker a rousing round of applause. So you are clearly doing this presentation from where you're working or rotating, and it seems like you are amongst COVID patients right now. Is that right, student Dr. Tong?
I am not, fortunately, but we do have a wing of this facility dedicated to a 14-day quarantine. And so patients are to not leave their rooms, physical therapies to stay within the room, etc.
So that'd be through contact tracing then?
Yes.
Awesome. Well, bless you for doing this, and becoming a doctor is becoming real, I would guess. Any other comments before I say goodbye to everybody?
Question
Dr.
for Dr. Ajada.
Say
How
again?
did you find such a smart girls and boys in your class?
They found me, and they are a group, and they are so smart. What I'd like to do is thank you, Dr. Schneider and Dr. Johnston, for your undying support in coming to these things. It means a lot to our students to have faculty support. Dr. Wolf, that includes you. Appreciate your attendance at these things. We're going to try to sustain this for a few more weeks, and we'll see what happens when the semester begins. Typically, these types of things kind of die off a little, but hopefully we can sustain it with support from you. Same story with the MKRC seminar series. I'd like to sustain it through the semester if possible on a trial basis. Let's see how it goes in terms of attendance. So once again, I appreciate everybody's attendance at this. It means a lot to me personally, to Ms. Boyer, and most importantly to our student doctors. It's a great opportunity for them to practice their skills that they're going to need in short order. Appreciate that.
Thank you. Goodbye.
Okay, take care, everybody. Have a great weekend.